A very good evening to one and all. Before I begin, I take this opportunity to thank ISA Ballari, WIMS Ballari, and Dr. Balbhaskar sir for giving me this opportunity. I'll be talking about science of pre-oxygenation, and my session objectives today are I'll be talking about oxygen in the atmosphere and alveoli, functional residual capacity with respect to pre-oxygenation, the concept of pre-oxygenation, its importance, and its drawbacks. So the air contains nitrogen in 78%, which is the major gas present. It is a relatively insoluble gas and does not take much part in the exchange at alveolar level. Oxygen is present in 21%, and we all know that it is the most important gas for existence of life. And the other gases like carbon dioxide and argon account for around 1% of the air. Whenever we talk about oxygen, the commonly used term is FiO2 or fraction of inspired oxygen. It is an estimation of oxygen content that a person inhales. So if the person is breathing room air, then he is inspiring the oxygen, or the FiO2 is 21% or 0.21%. As per conventional prediction model, for every liter of oxygen, the FiO2 increases by 4%. So if you are oxygenating a patient with the help of nasal cannula and you set the flows at 1 liter per minute, then the FiO2 increases from 21% to 24%. At 2 liters per minute, it increases to 28%, so on till the maximum FiO2 that can be achieved by that particular device is attained. Now, what is important is that if you want to achieve an FiO2 of 1 or 100%, then remember that there should not be any air entrainment, because if there is air entrainment, the oxygen is going to get diluted by nitrogen, and also there should not be any rebreathing if you want to achieve an FiO2 of 1, because rebreathing will lead to mixing of oxygen with carbon dioxide. And FiO2 determines the oxygen available for exchange at the alveolar level. It is only the available oxygen. It is not equivalent to the oxygen that is exchanged at the alveolar level, because oxygen transport is affected by multiple factors. Some of these include functional residual capacity, partial pressure of alveolar oxygen, the initial rise in the arterial carbon dioxide pressures, and shunt fraction, because if you are ventilating but that area is not perfused, it's not going to help in the oxygen transport. Cardiac output, because it determines the perfusion to the lungs. And hemoglobin concentration, because it determines the oxygen binding, and of course the oxygen consumption of the body. Now coming to the functional residual capacity, which forms the basic concept of our pre-oxygenation. FRC is the volume of gas that remains in the lungs at the end of passive end expiration. So for postgraduate students, please remember that respiratory capacities are sum of two or more volumes. So FRC, or functional residual capacity, is the sum of expiratory reserve volume plus residual volume, and it is approximately 30 to 35 ml per kg body weight. So why we are so worried about this functional residual capacity? This is because it is the most important store of oxygen in the body. And for an adult with normal FRC and oxygen consumption, the oxygen content of the lungs will be consumed within 1 minute. This explains why critical hypoxia can be expected after 1 minute of apnea. So if you want to prolong this safe period of apnea that can be tolerated by the patient, then you need to ensure that the FRC contains more oxygen. FRC decreases in conditions like diseases of the lungs, like if there is infection or pulmonary edema. Mechanical factors like obesity, pregnancy can decrease FRC. It is also decreased in supine position as compared to upright position, and weakness of the respiratory muscles, as is seen in old age, or in inadequate reversal of neuromuscular blocking agents, can all decrease the FRC. So what we need to understand is that patients with reduced FRC reach critical hypoxemia more rapidly. Now, functional residual capacity determines multiple lung functions, but what we are interested is that it influences the oxygen reserve during apnea. So how it influences, that we will see in the coming slides. Now, let us come to pre-oxygenation. So what are the guidelines for pre-oxygenation? According to the 2003 American Society of Anesthesiologists Task Force Guidelines on Management of Difficult Airway, they have stated that face mask ventilation pre-oxygenation should be initiated prior to the management of difficult airway. In 2012 guidelines by Difficult Airway Society, they have stated that pre-oxygenation should also be done prior to tracheal extubation. And in 2015 guidelines by the Difficult Airway Society United Kingdom, they have stated that pre-oxygenation should be done for all patients. This is because cannot intubate, cannot ventilate situation is unpredictable. So the need for pre-oxygenation is desirable in all patients wherever it is indicated. So what are the indications of pre-oxygenation? Pre-oxygenation should be done prior to intubation. So this could be prior to the general anesthesia or for some other indication. Remember that before you start the process of induction, start with pre-oxygenation. Every patient should also be pre-oxygenated whenever you are anticipating that you have to interrupt the ventilation, like you want to do some suction or change the position of the patient, disconnect the tube and change the position of the patient. Pre-oxygenation is also indicated prior to extubation. So pre-oxygenation before extubation is required because there may be some residual effects of anesthetic agents, and even though you have reversed the action of neuromuscular blocking agents, it may be inadequate. All this will lead to decrease in the respiratory muscle power. There may be decrease in the respiratory drive and the reflexes may not be adequately recovered. So there is possibility of hypoventilation and hypoxia. Therefore, routine pre-oxygenation before the reversal of neuromuscular blockade and tracheal extubation should be done. Now, what is pre-oxygenation? Mainly with context to pre-oxygenation before general anesthesia. Here, what we do is we replace the nitrogen in the lungs with oxygen in order to provide an apneic oxygen reservoir. So the aim of oxygenation is to replace nitrogen in the functional residual capacity with oxygen. Therefore, it is also referred to as denitrogenation, and it has a significant impact on the oxygen stores of the body, thereby increasing the tolerance to apnea substantially. So when we are pre-oxygenating the patient, what are our objectives? What do we want to achieve? So we want to bring the oxygen saturation to 100%. That is, whenever we start pre-oxygenating, we look at the pulse oximeter and we see that the oxygen saturation is reached 100%. That is, also we want to target an end-tidal oxygen of more than 90%. And we want to denitrogenate the residual lung capacity. That is, we want to achieve an end-tidal nitrogen of less than 5%. So basically, we want to maximize the oxygen storage in the lungs and in the bloodstream. Now, let us see the physiology of pre-oxygenation or how pre-oxygenation helps. So, if you consider a normal 70 kg adult, when he is breathing room air, the partial pressure of oxygen in the alveoli is equal to 13.2 kilopascal. This is equivalent to 13% of oxygen or 273 ml of oxygen in the FRC of 2.1 liters. So, as oxygen consumption at rest is 250 ml per minute, this 273 ml of oxygen will be lost in about 70 seconds of apnea. On the other hand, if the person is breathing 100% oxygen, then the alveolar partial pressure of oxygen increases from 13.2 kilopascal to 90 kilopascal, which is equivalent to 90% of oxygen or 1800 ml of oxygen in an FRC of 2.1 liters. So this should last for around 7 minutes of apnea. Now, how long should we pre-oxygenate the patient? So time constant in an exponential process is the time taken for the value of the exponential, which in this case is the amount of nitrogen in the functional residual capacity to fall to 37% of its previous value. After 4 time constants, the process will be 98% complete. So time constant relates to the ratio of volume and flow, and in case of lungs, it is the ratio of functional residual capacity with alveolar minute ventilation. So let us see how this works. So for a 70 kg patient, Considering the tidal volume at 7 ml per kg, the tidal volume will be 490 ml. And at a respiratory rate of 12 per minute, the minute ventilation, which is equal to tidal volume into respiratory rate, will be approximately 5880 ml. Considering the anatomical dead space of 140 ml, that is at 2 ml per kg, at a respiratory rate of 12 per minute, it is going to be 1680 ml. So the alveolar minute ventilation will be 4.2 liters per minute and the FRC will be 2.1 liters. So the time constant, which is a ratio of FRC to alveolar minute ventilation, will be 0.5 minutes. So to achieve 4 time constants, we will need 2 minutes to achieve a 98% of oxygen in the FRC to be washed out and replaced with oxygen. So a 3-minute period of pre-oxygen will ensure that there is a safe margin due to interpatient variability. Now let us look at this graph of the relationship between pre-oxygenation and denitrogenation. So the end tidal gas concentration of nitrogen and oxygen has been compared here during pre-oxygenation with respect to time using various breathing systems. What is seen here is that at 0.5 minutes, there is an equilibrium between the end tidal nitrogen and oxygen, and following it over a period of approximately 2 to 3 minutes, there is a decrease in the end tidal concentration of nitrogen and proportionate increase in the end tidal concentration of oxygen, after which it is an exponential process. So what we understand here is that at approximately 2 to 3 minutes, there will be decrease in the end tidal nitrogen of to 90 around less than 5%, and there will be increase in the end tidal oxygen concentration to around 90%. However, complete elimination of nitrogen from the alveoli is not possible. Now, this is about the pre-oxygenation with respect to the alveoli. What about pre-oxygenation with respect to the tissue oxygen levels? Does it help in increasing the tissue oxygen levels? Yes, though the maximum level of pre-oxygenation is at the level of lungs, it also helps to increase the oxygen levels at the blood. This is because pre-oxygenation will help to increase in the proportion of the dissolved oxygen in the plasma. Also, pre-oxygenation helps to increase in the dissolved oxygen in the tissue fluids. So, what we can understand here is the major effect of pre-oxygenation is on the FRC, and there is also a slight increase in the oxygen levels, stored oxygen levels in the blood and the tissue fluids. Thereby, pre-oxygenation helps in increasing the stored oxygen in the whole body. So how this pre-oxygenation helps? It helps to broaden the safe apnea period, which is described as the duration until a patient attains a saturation limit of 88 to 90%, thereby enabling the securing of a precise airway. So it is important to understand here that if the patients are desaturated below this point, that is below 90% of SaO2, then their state stands on the steep portion of the oxyhemoglobin curve. So as you can see that the oxyhemoglobin curve is a sigmoid shaped curve. What we do with pre-oxygenation is we extend this plateau phase of the oxyhemoglobin saturation curve. So once we pre-oxygenate, we know that this plateau is going to last longer. If we do not pre-oxygenate or we inadequately pre-oxygenate, the saturation is going to fall rapidly and then it will fall at the steep stage of the oxyhemoglobin curve, thereby causing hypoxic changes. So, coming to factors that affect pre-oxygenation, these can be classified into technical and patient factors for ease of remembrance. So, technical factors are factors which affect the fraction of inspired oxygen, like your fresh gas flows. and presence of leak. If there is presence of leak, the pre-oxygenation is going to get affected, and the type of circuit that you are using for your pre-oxygenation. Also, the method of pre-oxygenation, that is the type of breathing, whether you are using tidal volume breathing or your deep breathing, and the time for which you are pre-oxygenating the patient. Coming to patient factors, it is influenced by oxygen volume in the lungs, that is alveolar oxygen tension and the functional residual capacity. Pre-oxygenation is also influenced by the oxygen supply and demand balance in the body. That is factors like consumption of oxygen in the body, arterial oxygen content, and cardiac output are all going to influence pre-oxygenation. So now let us have a look at these curves which were given by Benmoff and colleagues in order to study the effect of pre-oxygenation with respect to oxygen saturation. So here what they did is they pre-oxygenated the patients for approximately 3 minutes at an FiO2 of 1, and they observed the saturation over a period of during the period of apnea that was achieved by giving succinylcholine of 1 mg per kg. What they observed is that a normal 70 kg adult withstands an apnea period of approximately 7 minutes without significant desaturation. On the other hand, obese patients and pediatric patients tend to desaturate very quickly. That is, they start desaturating within around a period of 3 to 4 minutes. On the other hand, moderately ill patients may not achieve 100% oxygen saturation even with pre-oxygenation, and they desaturate faster as compared to normal healthy adults. Why this occurs? Let us have a look now. So coming to obesity, obese patients may have multiple pulmonary abnormalities, like they may have decreased vital capacity, expiratory reserve volume, and functional residual capacity. Again, supine positioning further worsens the decrease in functional residual capacity, and obese patient also have the increased possibility of tidal volume decreasing within the closing capacity, thereby causing atelectasis. And because of all these factors, there is rapid oxyhemoglobin desaturation during apnea. And again, these problems are compounded by presence of difficult airway. So, adequate pre-oxygenation and proper positioning of the patient during pre-oxygenation is crucial in obese patients. Coming to pregnant patients, in pregnancy, functional residual capacity is reduced, and this is further reduced in the supine position. And in these patients, the oxygen consumption is increased, which steadily increases throughout the pregnancy. Generally, in pregnancy, we go for rapid sequence induction in order to avoid the risk of aspiration when we plan for general anesthesia. What is important here is that we should understand that pre-oxygenation is going to be achieved faster in pregnant patients because of their decreased FRC, and they also tend to desaturate rapidly as compared to normal patients during apnea because of the reduced FRC and increased oxygen consumption. Coming to pediatric patients, we have already seen in the Benmoff curve that pediatric patients desaturate earlier as compared to adult patients. This is because they have smaller FRC and greater oxygen consumption per unit weight as compared to healthy adults. Critical hypoxia develops more quickly after the onset of apnea, and this is more pronounced in younger children. So during apnea, in a 1-month-old child, the rate of decline of PaO2 is 3 times more rapid than that of adult. And pre-oxygenation helps in prolonging the duration of apnea with desaturation, thereby giving valuable extra time to manage these patients who may have difficult airway. So benefit of pre-oxygenation is greater as age increases in pediatrics. Coming to elderly patients, aging is associated with significant structural and physiological changes in the respiratory system. They may have weakened respiratory muscles, and there may be parenchymal alterations and a decrease in the elastic recoil, thereby decreasing the lung compliance, because of which there may be decrease in the lung volumes, ventilation perfusion mismatch may be present. They may have reduced pulmonary reserve, and oxygen uptake at the lung may be impaired. So even though they have decreased oxygen consumption, they tend to have a rapid desaturation during apnea. Coming to patients with pulmonary disease, the efficacy and efficiency of pre-oxygenation can be adversely affected by pulmonary disease because they also have decreased functional residual capacity, ventilation perfusion mismatch, and an increased oxygen consumption. So even brief period of interruption of ventilation, as is seen during suctioning or uh, during apnea for intubation, they tend to have significant desaturation. And pre-oxygenation in critically ill patients is influenced by a number of factors because they may have cardiopulmonary pathologies like decreased cardiac output, tissue hypoperfusion. There may be respiratory depression because of airway obstruction, ventilation, perfusion imbalance, and it may be compounded by other problems like anemia, hypermetabolic states, and pain. And remember, all these factors are going to negatively influence the pre-oxygenation. So critically ill patients suffer desaturation more rapidly than healthy patients. And in unstable critically ill patients, the initial PaO2 itself may be low. Pre-oxygenation as measured by the change in PaO2 is also decreased in these patients. However, pre-oxygenation is crucial and measures to improve oxygenation have shown a positive outcome. Coming to patients at high altitude, altitude does not alter the concentration of inspired oxygen and it continues to be 21%. However, at high altitude, there is reduced barometric pressure, which produces a decrease in the partial pressure of alveolar and oxygen PO2. So, as altitude increases, the PaO2 decreases exponentially. Whatever few studies are there, they have stated that at high altitudes, it is helpful if longer duration of pre-oxygenation is given. Now, coming to the risks associated with pre-oxygenation, pre-oxygenation may lead to delayed diagnosis of esophageal intubation. It may lead to absorption atelectasis, hemodynamic fluctuations, and production of reactive oxygen species. So now we have already seen that pre-oxygenation increases the time period before hypoxemia ensues. So minutes may elapse before esophageal intubation is recognized, which may result in severe hypoxemia. This especially occurs when you are using pulse oximeter as the monitor for your intubation, because we know that pulse oximeter reflects the fall in arterial oxygen relatively later. So it is better to use end-tidal carbon dioxide as a monitor for intubation. Coming to absorption atelectasis, it occurs in 75 to 90% of healthy individuals under general anesthesia and is the most common side effect of pre-oxygenation. So we know that normally oxygen shares the alveolar space with other gases, principally nitrogen. Nitrogen is poorly soluble in plasma and therefore it remains in high concentration in the alveoli. Now, during pre-oxygenation, what happens is there is rapid replacement of nitrogen with oxygen. This promotes loss of gas from the lungs to the bloodstream. That is, the oxygen gets absorbed into the lungs and the nitrogen goes out from the alveoli. This results in alveolar collapse, that is, absorption atelectasis. Absorption atelectasis can be decreased by decreasing the FiO2 and by use of recruitment maneuvers like CPAP, PEEP, or re-expansion maneuvers like vital capacity maneuvers. Pre-oxygenation may also lead to production of reactive oxygen species. Oxygen generally exists in the form of dioxygen. That is why we always say O2. So in biological tissues, dioxygen molecule can be accidentally or deliberately split, thereby producing reactive oxygen species. Some of the reactive oxygen species are superoxide anion, hydroxyl radical, and hydrogen peroxide. These can react with critical molecules like molecular components like lipid, DNA, and proteins, thereby causing significant cellular damage. This occurs generally when prolonged use of oxygen at an FiO2 of 1. So, the clinical manifestations of production of reactive oxygen species include pulmonary edema, acute respiratory distress syndrome, retinal detachment, retinopathy of prematurity, and sometimes it may also cause seizures. Signs of early lung injury begin to appear after 12 hours of high concentrations of oxygen breathing. So, what we need to understand here is that because of its short duration, Cellular injury due to reactive oxygen species actually does not apply to pre-oxygenation. Coming to cardiovascular responses of pre-oxygenation, administration of 100% oxygen can lead to a modest decrease in heart rate along with decrease in cardiac output. There may also be increase in the systemic vascular resistance and arterial blood pressure. These changes occur due to a reflex loop which may be chemoreceptor or baroreceptor in origin and mediated by the vagus nerve. Hyperoxia causes decrease in coronary blood flow because of vasoconstriction. This occurs because of its effect on the nitric oxide, which is the potent vasodilator at the coronaries. And hyperoxia also decreases myocardial oxygen consumption. High oxygen also reduces cerebral blood flow because of vasoconstriction. It also causes vasoconstriction, which may lead to decreased blood flow in the peripheral vascular beds, in the kidneys, in the GIT, and hind limbs. However, these are relatively insignificant. So, to summarize, pre-oxygenation is an important practice of anesthesia which is applicable prior to intubation, extubation, and interruption of ventilation. It helps in prolonging the duration of safe apnea period. It involves replacement of nitrogen with oxygen in the alveoli, therefore also called as denitrogenation. It helps in increasing alveolar and tissue oxygen stores. Pre-oxygenation is challenging in conditions like pregnancy, obesity, pediatrics, old age patients, critically ill patients, but is also of crucial importance in them. Hazards of pre-oxygenation include unrecognized esophageal intubation, absorption atelectasis, cardiovascular responses, and production of reactive oxygen species. However, advantages of pre-oxygenation significantly outweigh the disadvantages of pre-oxygenation. Therefore, pre-oxygenation is a must in all patients wherever it is indicated. So these are my references. I thank you all for your patient hearing.